Hi, my name is Luckshi Rajendran, and I'm a surgical resident at the University of Toronto.
Hello, my name is Gonzalo Sapisochin, and I'm an abdominal transplant and hepatobiliary surgeon at Toronto General Hospital within the University Health Network.
We'll provide a brief overview of our paper detailing the Toronto interim experience of our living donor liver transplant trial for managing initially unresectable colorectal liver metastases.
In patients with bilobar unresectable liver-only colorectal liver metastases, a total hepatectomy of liver transplant provides cure by removing all evident disease. However, it has been historically contraindicated in these patients for poor survival and recurrence outcomes. More recently, including the most prominent studies from Oslo, Norway, we have reintroduced a potential role of liver transplant with improved survival and recurrence rates, where we apply current chemotherapy and immunosuppressive regimens and a very strict patient selection criteria.
Unlike Norway, where liver waitlist time is less than 40 days, North America has a deceased donor shortage, and it becomes difficult to further expand indications for transplant. Living donor liver transplant circumvents this shortage. It leads to comparable, if not better, outcomes compared to deceased donor liver transplant and other liver cancers, and it's an elective operation, so we have control over timing of pre-transplant chemotherapy. So in 2016, UHN was approved to start a living donor liver transplant trial, and patients across Canada who were deemed unresectable were referred to the study. This was an open-label trial based on these various inclusion-exclusion factors. The main take-home is that patients were continued on chemotherapy, they received standard of care oncologic follow-up every 3 months while being assessed or waiting for transplant, and they had to demonstrate disease stability and remain unresectable. These results show our interim analysis from February 2023, but of the 106 patients who were referred, 91 were formally assessed in initial consultation. Of these, 36 were eligible for the study, and 7 went on to have liver transplant, with a median of 15.4 months from initial assessment to transplantation. 24 patients went on to have resectable disease and had resection with curative intent. 50 patients were excluded from the study, were not candidates for resection, and were referred back to medical oncology for consideration of further systemic treatment in the control population. There was no significant difference in the demographic and clinical characteristics between the transplanted, resected, and control population. The control population had significantly worse overall survival from the time of initial assessment compared to the resected and transplanted population, and the resected population had significantly worse postoperative recurrence-free survival versus the transplanted population.
These are really exciting times in transplant oncology, with transplant as a potential treatment option for select patient population with unresectable colorectal liver metastases. Though few patients are eligible for transplant in the end, the oncological outcomes of these patients are excellent. The process selects for those with good tumor biology to optimize the balance of providing the greatest benefits from transplantation while being mindful of the risk to both the donor and the recipient.